I'm proud about the National Health Service. It's a piece of real socialism.
Over the years, I've had quite a lot of dealings with politicians because quite a lot of the things that I've done as a result of my academic and clinical work have been political in nature. So I've had quite a lot of dealings with politicians. And I have to say, I haven't necessarily succeeded in persuading my colleagues in the Labour Party of the point of view. I had greatest success with Jeremy Corbyn and with Luciana Berger when they were speaking to each other. But Luciana was interesting because she talked to me about the perspective I take on mental health and suggested to me that although she, and to the extent that we had a discussion, Jeremy Corbyn tended to agree, because the perspective I was putting forward was very much an idea that people's trajectory in life is largely determined by their personal circumstances and the situations in which they find themselves, rather than some sort of eugenic idea of having good genes and being physically fit and healthy people. And the spin-off, which is some of us aren't as lucky as others, but rather than seeing that as a deficiency in the individual, seeing that as something that we as a community should respond to. That was the point of view I was putting forward. Luciana's argument was that she got that. She thought that Jeremy Corbyn got that, but the traditional view of the Labour Party was to support the NHS. And of course, I want the NHS reformed. I don't want the NHS to be delivering the sort of mental health care that it has been doing for the past 100 years or so. I think much of that is profoundly wrong, and I'm looking for change. But that doesn't mean undermining the NHS. It means very much supporting health and social care through community action and general taxation, but doing it in a different way. So that's my stall, and holding it out for people. That's where I come from. And this is quite interesting forum for me, because the idea of talking to fellow socialists about the implications of my work is interesting. 99.9% of clinical psychologists vote Labour, of course, or Green, but nevertheless, it's interesting to have the political down. This is basically kind of my thesis, really. About 10, 15 years ago, a bunch of us who were in the sort of critical, I suppose you could say anti-psychiatry, but more sort of critical mental health, we're in a room at the University of East London, and we were saying, what can the slogan be that goes on the side of the bus? And the slogan that goes on the side of the bus is, don't ask what's wrong with me, ask what's happened to me. And that's our basic contention. This is a little bit of work that I did with a colleague only a few years ago. We were looking at the archives in Liverpool Central Library of Rainhill Asylum when the mental health services got transferred to the National Health Service. The archives all got stored, which is wonderful, an enormous resource for people. Lord Shaftesbury, back in 1832, well, he started his work in 1832. By 1845, he introduced the Lunacy Act. And one of the things they did in the Lunacy Act is they created county asylums. They were basically socializing, bringing the asylum system into public regulation, really. So instead of madhouses, which were an available public resource, but privately owned, if you see what I mean. They created the county asylum, so a nationwide system of asylums, not yet in the health service because they weren't hospitals and there was no National Health Service, but nationally controlled. And the Lunacy Act included the admonition that people being admitted to the asylums must, in Lord Shaftesbury's words, have the details and circumstances of their lives that led to their admission to hospital recorded in minute detail and in a form that could be read by the layperson. And this is an account of a woman who was admitted to Rainhill Asylum in 1852. And the copperplate handwriting is quite difficult to read, but it says that insanity was brought on in this case by the loss of a child who accidentally fell into a well near the dwelling of the woman. And she saw the body being pulled out, and not knowing that it was that of her son, ran to help and then realized that it was her son who was being, a 2-year-old son, who was being pulled dead out of the well down near the docks, in fact, in Liverpool. She was admitted to hospital to the asylum the same day and was refusing food. And then a few days later, she started to refuse water as well. And she died on the 25th of January, 1852, after being in hospital only a few days. She basically stopped eating and drinking. And in 1852, because of the admonition that the circumstances of people's admission to hospital needed to be recorded in layperson's language, we have that record. By 1930, what had happened was that as we moved from essentially a social model of the madhouses, and I'm not defending all of the actions of the madhouses, but their principal role was social, we moved towards a medical approach. So over the years in the 1850s, 1860s, 1870s, we began to apply medical, quasi-scientific classification systems to madness. So the psychiatrists emerging as a profession developed the diagnostic tools that were then becoming prevalent in physical medicine. So you got the diagnosis of dementia praecox, the diagnosis of manic depression, major depressive disorder, and so forth. And this reification of the diagnosis increased over the years until by 1850, I think it was called the Mental Health Act in 1830, had shrank down the recording of the social circumstances of people's madness to what you can see on the, as we look at it, the right-hand side. So instead of the minute details of people's circumstances, you've got etiological factors and only symbols that were scheduled by the Board of Control. And you may make only one record for each case in the principal etiological causes of the woman's illness. So whereas in 1852, it is recorded that the woman was admitted to the asylum because she saw her son being pulled out of a well after drowning. By 1930, her problems would have been recorded as manic depression with the etiology of F2. What was replaced in the space in the admission records was a genealogical history, particularly interested in siblings and particularly interested in twin siblings who also had mental health problems. We think almost certainly because of the rise of the eugenics movement. So when we wrote this up, the title of our paper was The Progressive Diminution of the Role of Social Factors in Mental Health Problems. Over time, we've seen this shrinking of the role of social factors. Incidentally, I did a piece of work on Merseycare recently using data from 2015. And in less than 0.3% of cases were any social factors recorded for any of the 21,000 patients that Merseycare is caring for. What were recorded were primary diagnoses, many diagnoses, and no records of the social factors. So it's almost totally disappeared. Over that time, we've seen a massive increase in the number of people taking medication, self-active medication. So this is a headline from 2014, I think, where over the decade before 2014, the number of people taking antidepressant medication has doubled. It's pretty much doubled again. So now creeping up to 20% of the population are on antidepressants, mainly selective serotonin reuptake inhibitors. These are drugs that block the reuptake of serotonin in the interstitial spaces of the brain, initially lowering the threshold for the excitation of neurons that rely on serotonin. Of course, quite rapidly, possibly in a matter of weeks, the brain readjusts. One of the things that's notable, I sit on the NICE guidelines panel for the treatment of depression in adults, so we've seen all of this data. Nearly all of the outcome data for the effectiveness of antidepressants is recorded at 8 weeks. This is at the time where there would be the peak benefit for the blocking of the reuptake of serotonin, the peak benefit gained from what might be termed as an increase in the levels of serotonin in the brain, but before the brain downregulates serotonin receptor activity to compensate for the increased serotonin. And what you see is progressively less benefit from the antidepressants after that time. Most people who take antidepressants are not only on antidepressants for years, but they're advised to be on antidepressants for years, despite the fact that the evidence for their so-called effectiveness is gathered at about 8 weeks. If you play with the chemicals in your brain, it's likely to have an effect on your mood. There is literally no evidence. There was a recent systematic review, literally no evidence that serotonin abnormalities are responsible for people being depressed. And as I'll come on to show you in a minute, there are plenty of reasons to believe that people are depressed for lots of other reasons. The same pattern, well, one interesting pattern that you can see is that the pattern of antidepressant prescription correlates, not perfectly, but correlates with social deprivation. So the most socially deprived areas of Britain tend to have the highest levels of antidepressant prescription. Now, in some ways, this is not knocking doctors, incidentally. And the reason why it's not knocking doctors is because if you are a GP or a psychiatrist working in a socially deprived area, if you believe in a social model of psychological well-being, the logical conclusion would be living in a deprived area is likely to be depressing. People who live in socially deprived areas are likely to be faced with the circumstances in their everyday life which make them depressed. Therefore, they're likely to be depressed. And so the response by prescribing antidepressants in some way has a quasi-logical basis to it. Lots of people in Redcar and Cleveland are depressed. It's a very socially deprived area. And the system responds by prescribing antidepressants. I think that that is humane. I think that that is understandable, but I think it's profoundly wrong, because what we're basically doing is medicating people for social problems. We're not only medicating them for social problems, we are understanding their problems as being illnesses rather than responses to terrible social circumstances. We're labeling them as having disorders. We are telling them that they are defective. And we are quite explicitly telling them that the reason why they are depressed is because there is something wrong with their brains. And in some circumstances, especially with presentations of psychosis, people are told that they shouldn't have children because they carry the stain of genetic disease with them. What you see here is a rather misguided attempt to solve social problems with medication. The same thing happens in the case of problems at school, and I am not for 1 minute minimizing the problems that children are having at school. I'm not also minimizing the problems that children who are in a state of distress or exhibiting other problems cause for other people around them. So conduct problems in schools are problems. I think difficulties in paying attention and concentrating are problems. Discipline problems are problems. So there are a lot of kids who are struggling in our schools. Now, there are reasons for that. One of the reasons for it is that diagnoses like ADHD and the prescription of Ritalin closely parallel the developmental age of children. The diagnostic criteria for problems such as ADHD are basically acting in a childish fashion. So most people expect young people to have problems sustaining attention, and problems sustaining attention is a diagnostic feature of ADHD. And so it goes on. So most of the criteria for ADHD are effectively, this child is behaving in the target areas in a way which is developmentally lower than their peers. But of course, if you have a 5-year-old in a class in UK schools, the chances are that 2 or 3 of those kids are going to be 11.5 months younger than the other kids in the class. We also have a standardized curriculum, which in the UK finds it very, very difficult to respond to differential needs of children in the classroom. We have SATs tests and other expectations on teachers where the performance of the teachers and the head teachers, including their pay, it's judged by whether or not the kids are performing to expectation. And of course, the criteria for ADHD are basically, are the kids performing to expectation? The teachers and the schools get an exemption from those judgments if they correctly, in the view of the medical establishment, identify that the kids have problems and send them off the interventions that are seen to follow. So you escape from the idea that you are failing to teach your kids, and you fail and you escape from the punishment of the league tables if the kids are identified as having ADHD. All of the analysis of ADHD reveals that kids who are younger in the school cohort, kids that come from minority social groups, kids that come from socially deprived backgrounds, and kids whose parents have relationship difficulties tend to be much more likely in attracting a label of ADHD. When I get to this stage in the talk, quite a lot of people comment that there are biological findings for ADHD. People comment that there are biological findings for other mental health problems as well. I don't find them convincing, but it also is the case that if it is true that there are kids in our classrooms who, for neurodevelopmental reasons, struggle to pay attention, I think that that is an educational problem, and a problem that we should understand as reflective of the diversity of our populations, including the neural developmental diversity of our populations, rather than that some kids have diseases that need to be treated with, in this case, powerful amphetamine-like substances. So we've got what seems to be an epidemic of treating so-called mental disorders with the process of diagnosing people as having a disorder, that there is something wrong with them that needs to be treated or put right with drugs. I'm hugely skeptical. I'm skeptical because this is the consequence. This is a photo that was widely shared on Twitter by a Twitter user called Alison Cameron until the NHS trust that she was being cared for asked her to take it down. So I retrieved the photo and asked her whether I could use it, and she said, of course. So I'm using it with her permission. And this is, it's obvious what this is. This is the recreation, outdoor, maybe smoking area. This is actually a private hospital. I don't know whether it's profit yielding or not for profit, but it's actually a private hospital subcontracted to the NHS. The Human Rights Act, soon to be abolished by our caring Conservative government, says that we have an absolute right to freedom from inhumane or degrading treatment. And the test for that is, would an ordinary member of the public feel degraded if they were subjected to this treatment? I think our NHS is breaking the law every day. I would feel degraded if I was treated there. The legal defense, because I've been to court several times trying to argue this, the legal defense is necessity. So the NHS trusts say that it is necessary to treat people and that they have no alternative other than to use the services that are available to them. And I think that's a very weak argument. And I hope soon that somebody will win a human rights case against the NHS, to be perfectly honest. I think this is degrading. It is not what I would expect. If you believe that caring for people with mental health problems should be part of the NHS's remit, and that people with mental health problems should be treated in NHS facilities like anybody else with any other physical problem, fine, go with that. But this isn't the standards that we expect. So something is going badly wrong. In my opinion, it's because this idea of taking people who are vulnerable, who have suffered as a result of the social circumstances that they find themselves in, and then telling them that there's something wrong with them, that they have a mental illness, there's something wrong with their brains that needs to be treated, leads to this sort of consequence. It leads to the consequence that we saw in the recent documentary by Panorama about the treatment of people at the Edenfield unit under Greater Manchester Mental Health, with people being abused quite flagrantly. I believe that criminal investigations are still going on for the people there. It also, I think, leads inevitably to misunderstanding and inappropriate treatment. This is a photograph that I took in a place called Bathurst in Australia, and you can tell it's not the NHS because all the light bulbs are working. But when I show this to my friends, they say that, I ask them what it is, and they say that it's a hospital ward. And then they look more closely and see the armored glass between the patients and the staff, and they say that it's a psychiatric ward. The point here is that even when it's rather nice, were you to be admitted to this hospital, were you, for instance, be feeling suicidal? Suicide is quite a significant issue in the rural communities of Australia for social reasons. This would tell you that you're ill, there's something wrong with you, it needs to be treated as a medical complaint, and you need to be treated by medical staff. It also tells you that you, or possibly the people that you're in hospital with, are dangerous. There is something uncontrollable and dangerous about your condition that needs powerful medical intervention. And I think that's a concerning message. Why? Well, for this reason. So this has actually got Alex as an author on it. So apologies for this. Alex, I'm going to use your words as part of my argument. This is analysis that Ben and others did looking at the impact, not of COVID, and not of Brexit, but COVID and Brexit. I sit on a little group coming out of what was Public Health England, where we were asked to look at the mental health consequences of COVID. And we used this paper as the basis of quite a lot of our modelling. When they looked at the 2008-2010 economic crisis consequent upon subprime mortgages, etc., what they found was that as especially men, we live in a gendered society and employment profiles are different for men and women. When you look particularly at men who were made unemployed as a result of the economic crisis, you saw a spike in suicides. And I think, no, but I haven't put the tweet, but the Royal College of Psychiatrists, when this paper was published, used the word cause, that the economic crisis caused an increase in suicide. Well, that's an interesting word. I completely and utterly agree with it. I think we know that the economic crisis caused suicides, and the way that it caused suicides is the economic crisis caused unemployment, and unemployment caused people to feel hopeless and pessimistic about the future, feeling as if there's no reason or purpose in carrying on living. I think that is a causal link. But of course, that's absolutely, totally different from the idea that there is a mental illness that needs to be treated. We see it in terms of the migrant crisis. And one of the things that happens when I put this picture up is that quite a lot of people comment that if we were to take a diagnosis like post-traumatic stress disorder, I don't think that that's, like all of the others, I don't think that's a valid diagnosis, by the way. I think there are better ways to conceptualize these problems. But if you take a diagnosis of post-traumatic stress disorder, maybe 25% of migrants doing, in this case, Mediterranean migrant crossing, but also the Channel crossing, maybe 25% of those people will develop, present with mental health problems, post-traumatic stress disorder after the crossing. And of course, people say, well, what about the 75%? Maybe we should look at the 25%, wonder what's vulnerable about them, what's different. Maybe they've got different brains. Maybe there's something about them that means that they're not sustaining themselves. They're not resilient. The same thing has been used in warfare. If you read the report in 1922 about shell shock during the First World War, you'll see the same thing, where they said that a vast number of people who were psychiatrically disabled by the horrors of the First World War, one of the ways to look at it is that they were inadequate men in the first instance, and that the stresses of war revealed their inadequacy. Again, it's a victim blaming, pathologizing model. And one of the things that I would suggest is that, you know, if around Liverpool, the police were to reveal that somebody was going around Liverpool tripping people up, that it seemed like a little bit of antisocial nuisance, but it turned out to be quite serious, and he tripped hundreds of people up, some of whom had fallen over and broken bones because of his tripping, and it was a scourge that they needed to catch him, right? What you wouldn't immediately do is to go, tripping people up, injuries. I suspect that the people with injuries were probably elderly people. We really need to focus on osteoporosis. You would not do that. You would catch the person who's tripping people up, because you would realize that when you trip people up, of course, older people, people of my age, in fact, are more vulnerable to broken bones as a result of that sort of assault. But you would say that the primary cause of their injury was the assault. You wouldn't say that the primary cause of their injury was osteoporosis. People come in different shapes and sizes. Some of us are more vulnerable than others. If the people on this boat have got loving parents, they've got a strong foundation, they've got money in the bank, they are prepared for the crossing, chances are they'll be a little bit more resilient. But these are all social factors. This is not the brain chemistry of the individuals. There are reasons why people differ in their resilience to the challenges that we face, but the causal agency is the challenges that we face. Incidentally, they've subjected this now. One of the bits of evidence here is that, so if you take genome-wide association studies and you look at, personally, I think that the studies are largely invalid anyway, because if you take a so-called disorder like schizophrenia or depression, these diagnoses are so heterogeneous that it's almost impossible to tease out the causal links anyway. But let's say that you run with it. What you would find in the case of schizophrenia, when you look at the headlines, if you look on social media, what you'll find is a story that goes something like this, which is major teaching hospitals and news organizations say schizophrenia is a devastating brain disease, largely genetic in origin. And you go, really, is it? What brain abnormalities underpin schizophrenia? And they'll say something. They might give you their own pet theory, or they might give you weasel words about dopaminergic functioning. And I literally don't know what that would mean. I know what dopamine is, I know what functioning is, but I don't know what that is. Usually weasel words. And then when you ask about the genetic basis of these things, they usually say, well, we're doing some groundbreaking work here at the University of Liverpool, and we hope to have some major findings very soon. You go, yeah, what are they? And they're again weaselly. And then you say, do you have any evidence of genetic factors in any mental health problem? And sometimes they point to, like I say, genome-wide association studies, where many tens of thousands, sometimes hundreds of thousands of people's data is collated to look at the links between particular genetic variants that we all possess and the risks of developing these so-called diseases. Well, okay. So first of all, the data suggest that several thousand different genetic variants may each contribute a tiny amount of increased risk for the development of the problems that can be diagnosed as, for instance, schizophrenia. But there are many thousands of different variants, and each one of them, either in combination with other genome variants or on their own, convey a tiny increased risk. So tiny that you can only find it if you look at tens of thousands of people with highly sophisticated statistics. It doesn't look much like a genetic disease. It looks a lot like there are some genetic variants that might be associated with a tiny increase of variation. But that's enough for people to be advised, probably today, that they shouldn't have children because they've got a lifelong disease. When you look at depression, there is a candidate gene area for depression, or it was a while ago. So when you take SSRIs, when you take selective serotonin reuptake inhibitors, like I say, what they do is they inhibit the reuptake of serotonin. I don't believe the hype about antidepressant medication. I don't think it's nearly as effective as people claim. And remember, I sit on NICE, I've seen the data, and they have major adverse side effects, most of which are poorly documented. So the balance between benefits and harms is hugely skewed in favor of the profits of the pharmaceutical companies and the professional activity of psychiatrists. But if it's the case that SSRIs are effective, they're effective, the argument goes, because they block the reuptake of serotonin. Well, let's look at the genes for the reuptake of serotonin. And there's a gene, the 5-HTTP-LPR gene, that produces the protein that flips serotonin in and out of the nerve cells. So it makes sense to look at that gene and to see whether different variants in that gene might be associated with an increased risk of developing depression, either alone or in combination with stressful life events. Because we know, maybe I'm letting the cat out of the bag, but we absolutely know that stressful life events are associated with pretty much every mental health problem that you can name. What we find is that despite the fact that the SSRIs are touted to work, despite the fact that people bang on about serotonin and depression, what we find is that the number of stressful life events are associated with the onset of mental health problems, and we don't find significant interactions with genetic variants. It's the events that make us depressed. It's the events that make us depressed. If there is anything from genes, it's a tiny additional risk. The same, incidentally, is true for problems that are usually thought of as quintessential illnesses, disorders, and so forth. So this is schizophrenia. So what's the risk of reporting psychosis dependent on, in this case, the experience of childhood adversities? And when you look at, it's a very simple study, it's been done many times. This is one done at Liverpool by Filippo Varese and Richard Bentel and others. And here they were looking at 5 different types of childhood adversity. So you can have bullying at school, you can have poverty, you can have racism, physical abuse, sexual abuse. And what they find is that the odds ratio works the other way around. So that people who report psychosis are 3 times more likely than the general public to report adverse experiences in their childhood. when you look at all 5 of the 5 different types of adversity, the odds ratio between somebody child who's experienced each of the 5 different types of adversity, so that'd be a black child experiencing racism, being bullied at school and having physically and sexually abusive parents, for instance, that child is 124 times more likely to experience psychosis in adulthood than as a child who experiences none of those adversities. Now, and I'm not entirely sure that I quite buy this stats, but Richard Bentel, who's the senior author on this paper, said that the link between childhood adversity and psychosis statistically is stronger than the link between smoking and lung cancer. So we know that life events, negative life events, lie behind in some complex causal pathway, depression, anxiety, and of course, other problems. So that's why we say, don't ask what's wrong with me, ask what's happened to me. One thing to say at this point is, Alex talked just in the preamble about anti-psychiatry. Yeah, maybe. So Anthony Clare, who was very successful on TV in the 70s, 60s, 70s, 80s, wrote a book called Psychiatry in Dissent. R.D. Laing, Thomas Saz, Michael Foucault. These are all people who wrote blistering attacks from within psychiatry on psychiatry. So these are psychiatrists. This is quite an interesting presentation. So these are 2 editorials, effectively editorials, in the British Journal of Psychiatry, about 4 years apart, because one is a riposte to the other, and it takes a while to get papers published. So in 2008, Nick Craddock and several other professors of psychiatry said that what patients really needed is a return to proper medicine. These are devastating brain diseases. There's a rather telling phrase halfway through his paper where he says, if what you're experiencing is not a mental illness, but is in fact an understandable response to difficult social circumstances, then you don't need to see a psychiatrist, you need to see a social worker. But if what you're experiencing is a major mental illness, then you need to see a psychiatrist. Now, of course, for me, what does that mean? I mean that's the entire issue. So if you're depressed because bad things have happened to you, I think genuinely, I think it hinges on whether the psychiatrist that you happen to see that day can understand why you'd be depressed. And unfortunately, we're still in the case of people saying, do you know what, after a 7-minute conversation with you, I can't quite understand why you'd be hearing voices, so it must be an illness, and on the conversation goes. But anyway, Nick Craddock and his colleagues arguing very powerfully in this case that what we see are mental illnesses, that illnesses are illnesses, that these are illnesses affecting the brain, just in the same way that hepatic disease would be illnesses affecting the liver, and you need to see a specialist in the medicine of the brain and then be treated for it. On the other side of the screen is the response. These are all professors of psychiatry. They're all practicing consultant psychiatrists, and they argue exactly the opposite. That what they are dealing with as practicing clinicians are not diseases of the brain, but the human consequences of people struggling to make sense of a difficult and complex world. And sometimes those complexities are subtle. So at this point, I tell a story which is entirely true. So after my parents died, my sister was clearing out my parents' house, my mother's house, and they found a diary. And all through her adult life, my mother, unbeknown to any of us children, had kept a diary. And my sister was looking at an entry, or a set of entries, that my mother had written around not long after one of my brothers was born. This is before I existed. All my siblings are older than me. So before I existed in the world, my mother had written in her diary how she'd been to see her pastor. She was deeply religious, my mother. And she'd been to see her pastor because she was troubled. And she was disturbed by the fact that she thought that she was in immortal danger, because she realized that she was in danger of loving her children more than she loved Jesus Christ. Her pastor agreed with her that this was a worry. And so she documents in her diary how she was put on a little program of training to teach her how to love her children less. The vulnerabilities that we come with that shape our lives are not always obvious in a 7-minute consultation about biological symptoms. So Pat Bracken, Phil Thomas, Joanna Moncrief and others argue here that what they're dealing with in psychiatry are the human consequences of human interactions. I don't think there's anything wrong with the brain of Jacob Rees-Mogg. I think his behavior in backing Boris Johnson is not even bizarre. I think it's understandable, but I don't think he's ill. I think that if, as people that I know and care about very deeply, happen to believe that they served in the special forces during the First and Second Gulf War, when in fact that is not the case, I think that's no less understandable than voting Conservative, in my personal opinion. And I don't see why you have to invoke brain disease in the case of one and not the other. These are not only my views. So one of the reasons for putting up that picture is to say that this is not me as a psychologist saying that I disagree with the profession of medicine. This is to say that there are deep divisions within psychiatry, within the profession of medicine, about how to think about these things anyway. This is a report by a guy called Denias Puras, Special Rapporteur on the Right to Health for the United Nations. He's now resigned, moved on from that job and somebody else. This is a report he wrote in 2017, and you can see the sort of conclusions. So he's saying that this is advice to especially developing countries about how they shape their mental health services. And his advice is that the crisis in mental health should be managed not as a crisis of individual conditions, but as a crisis of social obstacles which hinders individual rights. Mental health policy should address power imbalance rather than chemical imbalance. And he goes further. The urgent need for a shift in approach should prioritize policy innovation at the population level, targeting social determinants, and, in his words, should abandon the predominant medical model that seeks to cure individuals by targeting disorders. And this is why I come into conflict, although I loved her, with Luciana Berger. The reason being is that the Labour Party for many years has not seen socialism, if it still believes in socialism, as meaning that the consequence is that our mental health, just like our personal living conditions, our wealth, the choices that we make about housing and education and so forth, it doesn't see mental health as a consequence of social determinants. But I do, and many of the psychiatrists and clinical psychologists that I work with do. So you can see that this idea is that what we're talking about is the social determinants of our trajectory through life evidenced in our mental health, rather than suggesting that what we have is some people who've got brain diseases and we need to slap the NHS cure at them. The NHS cure is inappropriate and doesn't work. Interestingly, psychiatry is immensely powerful. This is Norman Lamb. He was then Minister of State for Care Services during the coalition government. He's speaking at the launch of a report. The Royal College of Psychiatrists started working with us on this report and then dissented and produced a minority report. We were talking about so-called personality disorders, and the report concludes that we shouldn't use the term personality disorder, that the majority of people who get that label are women. The vast majority of women who get that label have been through tremendously difficult social circumstances, and it's associated with a very, very high degree of accuracy with abuse at the hands of intimate partners and abuse at the hands of parents or caregivers as children. So Norman Lamb said that he agreed, he liked this element of the report, that he, as Minister of State for Care Services, thought that we should be in the business of responding to the psychological needs of people, mainly women, who've been horrendously abused, and we should not refer to them as having a personality disorder. It hasn't changed. And he was Minister of State for Care Services. But I've got a better anecdote. I used to attend, well, I still do, but as part of a group called Mental Health Europe, I met every so often a Danish woman there. In one meeting, she gave me a copy of the biography of her daughter. Her daughter had died as a result of the consequences of large doses of antipsychotic medication. And it was a terrible, terrible tragedy. And the book documented this rather wonderful child who then sank into a sort of career of mental health problems, ended up being hospitalized on many occasions and taking vast quantities of medication. And there was a foreword in the book talking about exactly that. And the guy writing the foreword had said how he'd seen the family grow up, had seen this girl, that this girl had played with his own daughters. And it was a tragedy that, in his words, she was killed by the psychiatric system. Signed, the Prime Minister of Denmark. And you think, why is it that very, very powerful individuals like ministers of state and prime ministers are critical of the system? Reports are written, suggestions made. The United Nations report and yet nothing changes. So there's something in the system that makes it very sticky and very impermeable to change, and it's quite disturbing, really. So I've written about this. My suggestion is that we do things differently. So my suggestion is that what we are seeing here are not symptoms of illnesses, but they're psychological phenomena, experiences, problems, if you like. Sometimes they are problems. So if people have given up all hope for the future, I think that's a problem. I'm not going to be even-handed about it. I think if somebody is talking about taking their own life, I'm not going to be neutral about that and suggest that it's a valid choice. I'm going to suggest that people have autonomy and people can make their own decisions about what they do in life, but it's clearly a problem. But I don't think it's a symptom of an illness called major depressive disorder. I think circumstances in our lives and the way that we have responded to them and have learned to respond to them can explain why we become depressed, become anxious, can develop obsessional problems, can become psychotic and so forth. And I think that in the biopsychosocial model that everybody likes to talk about, I think the differences between us in terms of the biological makeup of our brain explain vanishingly little variance in our mental health trajectories. But the circumstances of our lives and the choices that we and others have made in order to respond to those circumstances explain the vast majority of the variance in our presentation with mental health problems. So I have a solution, not only in terms of conceptual models, but in terms of what we should do about it. And this is possibly a little bit niche, but it's kind of the practical consequences of the way that I see things. In ICD-11 and also in DSM-5, the American Psychiatric Manual, there are little known and little used diagnostic or quasi-diagnostic codes. The ICD, because the World Health Organization like these things, like to record people's experiences and like to record the causes of people's experiences. And non-diagnostic record keeping in ICD is very prevalent. If you talk to psychiatrists, they will probably tell you that diagnosis is vital for their practice. And, you know, the pathologizing of our mental health is ubiquitous. In fact, a PhD student of mine and myself did a freedom of information request on NHS trusts to ask their various units what their entry criteria were. And in almost no cases were people required to have a diagnosis in order to enter the services. And there's a very good reason for that, which is the services do the diagnosing. So you get a referral to a service and the person who accepts you as a patient will then make a diagnosis that will be put in your records. But you don't have to have a diagnosis in order to access it. If I went psychotic this evening and my partner phoned up for an ambulance, I would be admitted or not admitted to a psychiatric unit, and they would not need a diagnosis in order to admit me. In fact, they almost certainly would not give me a diagnosis for quite a considerable period of time because they'd have to assess me first. You usually get a diagnosis, in fact, on discharge. So services don't seem to be predicated on diagnosis. Treatment kind of is. But in any case, in the World Health Organization, of course, there is much that doctors do which is non-diagnostic. If I go for a well-man check, they may or may not provide me with that resource, especially because GP services are under pressure at the moment. But it's not, I don't have to have a diagnosis in order to get a health check. If I go for contraceptive advice, I'm not diagnosed with sexual activity disorder. The GP just gives me contraception advice and gets billed for it. You get paid for it. It's a remunerable activity. If I ask for advice about how to keep healthy in the sun, you know, this is something that doctors do. There's loads of stuff. Pregnant women are not ill. They don't have a diagnosable condition, but we respond to them with healthcare. There's loads of stuff that the NHS does, which is not in response to diagnosable conditions in physical health. And so the ICD have a lot of non-diagnostic codes. And when it looks to mental health, they're really interesting. So you can talk about depressed mood. You can talk about anxiety. You can talk about auditory hallucinations. You can talk about obsessional thoughts. You can talk about non-suicidal self-injury. You can talk about suicidal ideation. There's a whole load of codable phenomena which are not illnesses. We almost never use them, but they could be very helpful. We also have in World Health Organization codification formal ICD-10 and 11 codes for psychosocial variables. These are not diagnoses. They're not, in fact, people's personal experiences. They're the circumstances behind us. They exist in ICD codes, but they very rarely appear in our healthcare records. And they include things like trauma, abuse, abandonment, and they include some interesting codes recognized by the World Health Organization of things like inadequate housing, lack of adequate food, Z59.S is extreme poverty, Z59.6 is low income, and there is even a code for insufficient social insurance and welfare support, which is Z59.7. So we can code for the sorts of problems that Daniel Blake presented with in I, Daniel Blake. They exist in the World Health Organization, they're codable, and they are not illnesses. So when we're presented with somebody who apparently has a diagnosis of moderate personality disorder, there is a code in ICD-11 for it. You can go online and search for this. There's a code for being injured by underpants. There's a code for being bitten by a parrot. There's a code for being hit by a motorboat. There is a code for the government not giving you enough pension. They exist, they're never used. So moderate personality disorder is 6D10.1. Or we could code for a personal history of sexual abuse, a history of spouse or partner violence, low income and threat of job loss. And you could then say that the person is presenting with anger, low mood, guilty feelings, and has harmed herself. I'm talking about her because the diagnosis of personality disorder is more usually given to a woman. If I, as a clinical psychologist, got a referral from a GP saying, please see this woman, she has a moderate personality disorder, I would not know where to start. I could not make a formulation on the basis of a diagnosis. But if you tell me that she has a personal history of sexual abuse, etc., I would know what to do. I do occasionally some works for the court. When you're writing a court report, saying that a woman has a diagnosis of personality disorder can only be useful for the court if you misrepresent the data. If you say that that diagnosis means something about her likely behavior and her emotions and her responses to situations, which it doesn't. But for a court even, understanding how to dispose of somebody who's, for instance, convicted of a crime, in the context of that, you would know as a judge how it would affect your for instance, your sentencing decisions. What you do about somebody who's convicted of a crime with a moderate personality disorder, God alone knows. But convicting somebody of a crime in that circumstance with a professional input, you would start to have a handle on why they did what they did. And it's all there. Like I say, QE 31, insufficient social welfare support, and there you go. Work burnout is one. For those of you who are following the UCU action, if there are problems in the workplace can be broken down into various difficulties with boss and so forth. You have to make a professional judgment as to whether the things that people are talking about warrant being included as causal factors in their psychological well-being. But that's the job that we're paid for. That's what we do. Sometimes we don't. Sometimes we think that people are talking about issues which don't appear to be more than the average stresses experienced by everybody in everyday life. But quite often we make a different decision. And this is the basis of formulation, not only for psychiatry, or should be, in my opinion, but also for clinical psychology. The point about clinical psychology as a profession which makes formulations is you take people's presenting problems, their experiences, the phenomena that they are experiencing, low mood, self-harm, pessimism, anger. You take the factors that they report have happened in their lives, abuse by partners, abuse by parents, unsafe working practices and so forth. And you use that to build a formulation, a story about what's happening. This is extremely different from the idea of diagnosing people with illnesses and then treating them. And my point is that this audience, and this is the argument I had with Luciano on many occasions, I think this is a socialist, or at least it's compatible with a socialist account of mental health. Yes, it's true that if you think about a socialist approach to cancer care, you would want cancer care to be well funded, to be funded out of general taxation or some form of proportionate taxation and free to everybody at the point of need. I agree with that too. I agree with that for psychological care, mental health care. I think that people like me should receive salaries from the state and be managed in a system of nationwide health and social care to provide care for people free at the point of need. But I don't think that what we're talking about are illnesses that need to be treated. I think this is a social and psychological phenomenon and not a biomedical phenomenon. I think things have gone badly wrong in the way that we provide it. So I think we need a change in the way that we understand and then provide services for people. When we do that, it's seen as successful. There was a paper out only a couple of days ago that basically a psychological approach. There's a rather obscure framework called the Power Threat Meaning Framework that I was lucky enough to be a co-author of that seems to be effective at helping people think about their services in such a way to reduce restraint, coercion, and excessive medication for people. More generally, this formulation-based approach is useful. This is a woman called Emma Williamson. This was quite a groundbreaking. This is taken from a newspaper article. Groundbreaking work down in Lambeth with homeless people, where working as a clinical psychologist, she was employed under Section 75 rules, and then she was a clinical psychologist employed by the NHS, but working in social services, working in a homeless hostel. But she deliberately took the view that her job was not to identify those homeless people who had mental illnesses and then treat the mental illnesses. Her job was to work with the homeless hostel to do formulation as a psychologist for anybody who needed it. So she didn't distinguish between people who were homeless but didn't have a mental illness and those people who did have a mental illness and then treat it. She worked with the system, she worked with people. So she came up with a formulation for people, regardless of whether they met or didn't meet the criteria for mental illness, with very positive success stories. I put this up to talk about the idea of what we could do rather than diagnosing kids with ADHD. Unfortunately, my suggestions for ADHD are expensive and grandiose because I would start formal education much later. I would not have kids all enter the school year at the same time, regardless of their developmental or chronological age, but I would stagger things. I would not put league tables and SATs tests on kids. I would try to nurture their cognitive development rather than force them into a process of education. I would see difficulties in conduct, learning, attention, memory, focus, concentration, and so forth as primarily educational, social, and psychological phenomena first, rather than medical phenomena. And I would be very wary about diagnosing people with kids with disorders and giving them amphetamines. The reason for putting up this is the forest school movement, the idea that kids who struggle with mainstream education possibly need better education. I think Alex might have been with me at a conference we both attended in Washington, DC, of the American Psychological Association, where one of the speakers, and I don't think it was Alex, but it could have been because he was similar, had a jacket on, and under it was a T-shirt that said, "I do not have ADHD, you are a boring teacher." That's it. Change the system, don't medicate the kid. It might have been Alex. It's the sort of thing Alex would do. And then now I'm slightly disappointed with this photo because just after I took this photo, this is a protest in York where Rachel Maskell, the MP for York, and myself and Len McCluskey spoke. We were opposing the closure of a psychiatric unit. The reason why I like it was because this is me as a clinical psychologist doing political stuff. This doesn't mean that because I'm opposed to the medicalization of human distress, psychological distress, that doesn't mean to say I would remove services from people. I would just provide them differently. And me and Rachel spoke at it. And I was very pleased with it because Len McCluskey spoke as well, very well. Unfortunately, he later came out in favor of Brexit, which kind of spoiled it a little bit, but I'm still very proud of the fact that so this leads, rather than increasing our skills in diagnosing and medicating, we need to increase our political and social activity in order to protect people from social harm and respond to people when they present with the psychological and behavioral signs that they have in fact been harmed by the social circumstances in which they grow up in. And like I say, that's for me, not only the culmination of the way that my science as an academic clinical psychologist tells me is the nature of mental health problems, but it's a profoundly socialist approach, because I see people's psychological distress as predominantly the consequence of the social circumstances and social environment in which they grow up in, rather than disorders of a dysfunctional brain that need to be treated with diagnosis and medication. On that point, I shall shut up and stop and invite questions. So thank you very much.
Thank you very much.
Well, thank you very much, Peter. Gosh, that was very comprehensive, and to 8 knots, you covered a heck of a lot of ground. As I'm chairing this, I perhaps can take advantage, whilst the rest of you are thinking of your questions, to ask the first one. There used to be a term called co-production. This is basically where people who were recipients of services actually worked democratically with those providing services in the best interests of everybody. It was called public and patient participation. And there are lots and lots of meetings that were about this, and they've all seemed to have disappeared altogether with the introduction of the ICB system. There is no participation. You're atomized into an individual who can just ask a question which they may or may not choose to answer. This is not the same thing at all. I can remember working collaboratively with lots of groups, locally and nationally, in order to improve the system and move forward. It seemed to be extremely progressive and worked well, but those bodies were not, they came to the end of their grant run and then they were not refunded. And so they've all disappeared. And all the work that was done, all that work that was so useful, all disappeared. It's criminal in my view.
Yeah.
So I think that.
Turn it down.
So one of the things I think has happened over the past 12 years, and I do lay it at the door of a Conservative government, is quite a lot of those things have been removed. David Cameron, for instance, and some of the people on the sort of One Nation wing of the Tory party are quite positive about healthcare as being a collaborative enterprise. But I think, as we're seeing with the NHS, and as it becomes a corporate beast, it becomes more difficult. We've seen colleagues in Public Health England told not to talk about. Right, am I echoing? So I turned my.
Yes, you are echoing.
Right. How do I deal with that?
I think we all need to unmute, except when you're speaking.
Well, it stopped now. It might have been that, Judith, you had your speaker still going or your microphone still going while Peter was talking. Now you're mute. It's all right. Okay. Oh, well, so I think as the NHS gets pressurised, I think they're not luxuries, but I think they get cut. I think it's also a particular. I think when you commodify medicine, it's useful. So I was quite proud to be involved with the IAPT program to develop psychological interventions. I could see the weaknesses of it. I could see the weaknesses of it then. This was in large part championed by Richard Layard, and his Blairite view. I voted for Blair, right? I quite like Blair. I'd rather have Blair than Johnson. It's just, there you go. I know that's not anyway. I voted for Starmer too, but anyway. And I voted for Jeremy Corbyn. I voted for them. All of my people I voted for ended up being leaders, and maybe I'm responsible. Anyway, but Layard said, commission these services as specific services, but they become commodified. So you get a manual, instead of increasing the resources available to a unit, you buy a block of cognitive behavior therapy, and it becomes commodified. And I think the
sort of public involvement tends to weaken a little bit. There was a nod towards it with patient governors, but I think for me, I'm sorry about this if it's kind of politicizing kind of this area of work, but I see the medicalization of psychiatry as part of that. So people are seen to have illnesses that require treatment. That's where the expertise lies in the hand of the psychiatrist. If you think that you're depressed because your mother was a cold and unfeeling woman, well, the professional will tell you whether you're correct or not, but it'll be the professional's decision and not yours. And if you think that you would prefer to have psychotherapy rather than medication, well, you'll have to plead with the prescribing physician in order to make that happen. You won't get it because you demand it. You don't have a right to these things. There's the concept of insight. So, still we talk about in psychiatry quite a lot that people lack insight. So I, for instance, do not believe that the diagnosis of schizophrenia has scientific legitimacy. I do not believe that there exists a disease called schizophrenia. That in itself would be grounds for sectioning somebody if they are also presenting with hallucinations and delusions and so forth, because lack of insight would be an additional contributing factor for their presentation. But I agree with them. So this pathologization of people's presentation, the idea that there's something wrong with them, that they've got errors in their thinking, that they're wrong, that they're deluded, that they're not seeing the world right, makes it easy for people's viewpoints to be excluded. And I think that, coupled with a right-wing agenda of services being commercialized and commodified, that the providers, and in this case, the prescribers are the people with a whip hand, I think that squeezes people out. I'm the director, one of the directors of a charity. We're building a residential unit in Ireland. So the idea of co-production and having residents in the unit that we're building as people responsible for running, it's going to be a working farm on a day-to-day basis. It's not new. It's been done with therapeutic communities for years, but it is a change from how traditional services are delivered. So I completely agree with you, Judith. I think the co-production issue is vital. I think it's seeing us as people who, because of the circumstances that we find ourselves in, struggle with our mental health, rather than supplicant patients to the psychiatrists who need to be treated. So I'm all in favour of it. Hopefully, under a socialist government led by Keir Starmer, we'll get a move back towards that, but I doubt it somehow.
Right, if we can go through Alex and then Ruth, and I'll mute now, but Alex and then Ruth to follow, please.
Okay, thanks. Can you hear me okay? Can you hear me okay? Oh, nobody's replying. Am I muted?
No, sorry, we forgot about your eyesight. So
Yes.
we all stuck our thumbs up and you can't see. Sorry.
Oh, sorry. Okay, first of all, can I thank you very much for a fascinating presentation, Peter. Very interesting, very enjoyable. I want to ask you about a sort of major dissonance in that you're clearly, even if you don't acknowledge it, a sort of revolutionary socialist. But I won't tell Keir Starmer. But, it's clear from what you say that you accept and believe in the social determination of mental illness and mental health. And I would imagine, given what you've said, that you would agree that there is a lot in societies which are capitalist, patriarchal, and racist that generates mental health problems. But in fact, while your critique of mental health, is revolutionary, your proposals were all reformist, and they were about how you would wish to change services in our existing neoliberal, patriarchal, racist society. Now, I'm not seeking to put you on the spot or anything. I'm actually interested in mental health promotion, but basically, in order to promote mental health in any society, you have to have a vision of the light at the end of the tunnel, as it were. You can't get off at Edge Hill. You have to go all the way to Lime Street. So I want to ask you, what kind of society would you tell us, what kind of society is optimal for mental health?
Thanks. So I'll address that first. I mean, we know from Wilkinson and Pickett's work and Marmot and so forth that unequal societies are bad for our mental health. And we know that the more equal a society is, the better it is for our mental health. And we know that there are a vast number of political decisions that are made which either foster or inhibit equity. And we can see some societies that are more equitable. I mean, quite a lot of the quite equitable societies aren't perfect. So you can see in some of the Scandinavian countries that there's quite a lot of racism in those countries, and there are other social ills. So we know that open, equitable societies are good for our mental health. We know that, well, I believe strongly that a combination of social equity and personal autonomy is very good for people. And one of the reasons is that Wilkinson and Pickett talk about how social comparison makes people unhappy. That in unequal societies, there's a lot of social comparison going on. There's quite a lot of evidence, especially interpreted through a framework of a theory called perceptual control theory, which is an overarching theory of human motivation, really, that when societies are unequal, large numbers of people have less control over the factors that influence their chance of happiness. And so one of the things that healthy societies need is that they need to foster the ability of individuals to control important variables in their lives. And of course, we can't in many ways. So this would be, local democracy, participation in local democracy. It would mean openness and transparency in communication, less secrecy. It would mean a much flatter social hierarchy and so forth. We also know that active social adversities affect people's mental health. So the sort of society that I would be aiming for would be one where protection of individuals against harm of various kinds would be the principal role for the police rather than the defense of the state and commercial operations by oligarchs. So we can see not quite defund the police, but are thinking about what citizen policing should be in a socialist democracy. We would be focusing on, yes, fostering development of children, including intellectual development of children. I want kids to go to school, I want kids to learn, I want there to be a lot of education, and I want education to continue through to the age of 21 or whatever. I believe in education. But I'd want it to be focused on personal development rather than meeting the milestones that capitalist employers want. There's that wonderful advert that the government produced only a few months ago with Becky, who wanted to be a ballet dancer, but now luckily we've trained her to be a coder for Google, and you just think this is terrible. So that's the sort of society that I want. When I sit down with individuals as a therapist, I don't tell them, I don't say, look, the thing is, Alex, I know that you've been depressed recently and you told me that you're thinking of ending your life. What you really need to do is vote for a more socialist government. Off you go. By the way, you can have 180 quid from a session fee. That's not what we do. So there are individual level responses, there are therapeutic responses, there's work that we could do to improve somebody's immediate environment, and then how we change the world. So I think, I'm also focused on what realistically we can do to improve the health and social care system. It's also the case that if we protected children as much as we possibly could from abuse from their parents, we would still not do it perfectly. You know, I'm not a Soviet socialist, so I don't believe that when we set up the perfect socialist state, no parent will ever abuse their children. I don't believe that will happen. I think that there are lots of things that happen, and just as an illustration, I mentioned perceptual control theory earlier, but also physical health is profoundly anxiety provoking. I've seen friends die of physical health problems, and to approach death while suffering from terminal cancer is terrifying. And you won't make people unterrified of death by having a socialist republic. Jung said that it's impossible to be a fully functioning human being unless you accept your mortality. And most of us are terrified of dying. There's something called terror management theory that suggests that quite a lot of mental health problems stem from people's inability to properly prepare for their own death. And maybe it's inevitably impossible. So I think whatever we do in terms of a socialist utopia, there's going to be problems. I had many ambitions when I was a teenager. I failed to achieve most of them. And I will go to my grave disappointed and despondent and unhappy. And I've got to live with that. So I think even in a socialist utopia, there will still be social factors that will mean that people will be depressed and anxious, and we've got to have services to respond to that. You know, floods will happen, people's houses will burn down. About 2 weeks ago, I saw a kid literally outside the window I'm looking out of now, hit by a car while on a scooter going down the road. Tragedies happen to people, and they have psychological consequences. So we need services even in a socialist utopia. So I want both. And you know what those services are, I think also realistically, if I was Prime Minister tomorrow, I'd be faced with a ruined economy. And I'd be faced with disillusioned nurses and overstretched social workers, and we've got to build it back up. Now, speaking radically, one of the things I put in my books is I would actually transfer the mental health services from NHS control to social services control. I think they're predominantly social services with medical input, not predominantly medical services with some social input. So I would change the top line management. It's still the Secretary of State for Health and Social Care. It would still be Andy Burnham in the case of Manchester. But I would see it as a predominantly social and psychological service with medical input, and not predominantly a medical service with some social input. So I would talk about residential units for people in great distress or are hugely vulnerable, not hospitals. And I would profoundly rejig that, but that would still be a reformist agenda for the estate that we have. I'd still have psychiatrists. I'd just have fewer of them. And I'd actually, bizarrely, I would want psychiatrists to be proper doctors. A lot of people are taking the drugs. The drugs have profound adverse effects. We need to understand them medically. We need to think about the prescription. We need to think about how those drugs interact with other medication people are taking. We need to think about withdrawal. Possibly we need to do genome testing. I mean, why is it that antidepressants work for some people and not others? Well, since we've all got genetic variants in terms of the way that our serotonin system works, you know, maybe the antidepressants are suitable for some people and not others, not on the basis of their psychological presentation, but on the basis of the way that their serotonin system works. None of that is tested. You don't get any medical biological tests in psychiatry, none. So I think there's a lot that medicine could do, but I think there's a lot that medicine can do in the service of what's primarily a social system. So if you wanted the real radical approach, what I'd do is I'd send a memo to all NHS chief executives asking them for an 18-month plan to hive off their services, including the physical estate, to the management of the local director for social services, and to think about Section 75 employment for the psychiatrists and nurses. That would be my radical solution. I'd still employ them, but I'd employ them in a different system.
Thank you.
Go on, oops.
Ruth, do go ahead. Alex, can you put your hand down now?
Oh, sorry, yes.
Yes.
Thanks. There is so much of what you said, Peter, that everyone in this room would agree with. The effects the stress effects of social conditions and so on, the pressures from capitalism, the pressures from the pharmaceutical, I suppose, society. I'm going to focus on the things where I felt I disagreed with you or felt dissent. And I think I wanted, and I feel as if I'm doing it from a point of a lack of knowledge in some ways, but I do feel it quite strongly. As a person for many years has represented those boring teachers, I do think that we will not solve all problems by forest schools, however valuable they are. So that is, I do think there are children and adults who are in genuine distress, whatever the label is given, and where in many cases, medical or therapeutic intervention is a real relief to them. From one of my jobs, I do come across, as a benefits advisor, I do come across a lot of parents who have children who have now been diagnosed with ADHD, because Alder Hayes seems to be doing, you know, a lot of diagnosis just now. And to those parents, it is a huge relief because they have been seeing behavior which they can't explain and which is distressing for the child. Whether it should be treated medically or not, I don't know. But the diagnosis has been a huge relief. And I'm not prepared to believe that those parents are all secretly abusing their children or misunderstanding the effect of their authoritarian or society on those children. Conversely, I've also spoken to people with conditions that have maybe been diagnosed as schizophrenia or whatever, but who have felt a huge relief from medication because it means that those voices, for instance, which are insistent and distracting, are silenced. And I think I have also, and I don't think anybody could have reached the age of most of the people in this room without having knowledge of families who've had one child or one person in the family who is suffering tremendous mental stress, which cannot immediately be related to social or external events. So I suppose what I'm saying is I am very uneasy about the concept that mental illness is a myth. And if that is may not be what you're saying, I can see you shaking your head. And I would also be very uneasy if any of those people who are in deep distress were refused or were less likely to access treatment, including treatment by using drugs. If
I share.
Let me just finish then. So my last, because we were ideologically telling them, no, you are not mentally ill, you are suffering from adverse conditions and our society. So my last question really is, the people who can speak best about these would be the people who have been diagnosed with mental illness and the families of those people, you know, in the case of children. So do you have any sort of references, or can you refer us to groups that would be making that? So that's my questions.
Okay, so I mean, I literally agree with everything that you said, apart from the points that you're making. So are there people, children, for instance, who are experiencing real problems and suffering immense distress? Yes, of course. Suicide is the second most common cause of death in young people after road traffic accidents. You know, mental health problems in their broadest capacity rank alongside musculoskeletal problems as the most common reason for people giving up work. So, yeah, and we've got 20% of the population taking antidepressant drugs. Something like 40% of university students receive diagnoses for mental health problems. I mean, there's absolutely no way that you can conclude that there are no real problems, that people are not suffering immense distress. Absolutely. So I did not say that. I said that at the beginning. I said it very clearly. I said it very loudly, and I'll say it again. Secondly, not all those people are abusing their children. I never said that either. I do not believe that all mental health problems stem from people abusing their children. I didn't say that. I talked about, for instance, I talked about friends of mine dying of cancer. I did not say that the prospect of imminent death is trivial, and in fact, they've been abused by their parents. I did not say that. I didn't say that. I didn't say that. It's often what is said to us. I mean, a lot of people on social media go, oh, those people, they think it's all trauma. I didn't say that. I don't think that. Then there's the question of diagnosis giving people relief. Yes, of course it does. People are confused, they're frightened, they know that they or the people that they love have immense problems. And when they're given a diagnosis, they absolutely get relief. It's also the case that when people are given medication, it helps. I've taken antipsychotic medication myself. I know what the effects are. I haven't taken antidepressants, but a lot of people say that medication helps. I think it often helps in the short term. I think that the only data that we have on medication, either antipsychotic or antidepressant medication, and certainly anxiolytic medication is short term. They're used long term, but the only data we have is short term. Yeah, absolutely. The idea that psychoactive chemicals aren't helpful to people is a little bit odd. We've been taking psychoactive chemicals for like 100,000 years. They're very, very common. So of course medication helps. I'm not said that it doesn't. So I don't think that everybody's abusing their kids. I don't think that we should deny the benefits of medication. I don't think we should say that people don't benefit from diagnoses. Diagnosis brings massive relief. My point is we could do much better. So our response to those absolutely, definitely 100% real problems is that we tell people that they're ill. I think we should address the problems. Why is this person hearing voices? If we say they're hearing voices because they've got a disease called schizophrenia, how do we know they've got schizophrenia? Because they're hearing voices. Oh, what is schizophrenia? Schizophrenia is an illness that makes you hear voices. How do we know they've got schizophrenia? Because they hear. It's just a circular statement. Whereas we do know quite a lot about something called source monitoring, which is about how you tell the difference between whether you're hearing something or whether you're thinking it. We know about how flashbacks work. We know about how fantasy works. We know about how memories. We know quite a lot about the psychology of hearing voices, but that's somehow not translated into what happens when people are diagnosed with schizophrenia. We know quite a lot about certainly the sociology of kids who present with problems that are diagnosed as ADHD. We also know quite a lot about what helps people. Yeah, so I'm not a prescriber. I don't prescribe medication, but I do work as a psychotherapist and I help people. So yes, diagnosis brings relief to people. It clears up confusion, I think in a slightly inappropriate way, because like I say, we basically tell people that the reason why they're experiencing problems is because there's something wrong with their brain, and there is literally no evidence for that. In the case of the vast majority of people presenting with mental health problems, there is, yeah, I will say it again. In the course of my career, I have not come across evidence supportive of any coherent biological explanation for depression, anxiety, obsessive compulsive disorder, ADHD, autism, schizophrenia, personality disorder. Those explanations do not exist. So what we've got is a label with a purported disease entity behind it, but no evidence for it at all, whereas we do have a lot of evidence for their social causation. What I'm arguing is not that we should junk all of that, but that we should use formulation, which is to take the evidence, including the evidence of biological factors, and try to explain why people are experiencing what they're experiencing. I am not suggesting that people should be refused treatment for ideological reasons. What I was suggesting, in fact, is that the directors of mental health trusts should report to the directors of adult social services for the delivery of the services that they provide. That's not refusing people treatment because I'm ideologically opposed to it. That's saying that there's a different ethos of care that may be more effective for people. I'm actually building a residential unit in Kildare in Ireland in order to provide care to people. I'm not suggesting that people should be refused treatment. Where I do disagree is the idea that the problems are not related to external stress. And I pick up a little bit on the external. So when you talk about terror management theory, there's a long-standing tradition in psychology that coming to terms with the fact that we're going to die is difficult. So I'm 57. I've recently, in fact, earlier this month, dropped my hours at the university. I'm thinking about how I want to spend the remaining years of my life. I think that's a wise and sensible thing to do. When I say that to people, they get a bit shirty about it because quite a lot of people like to pretend that they're not going to die. I think that's ludicrous and will lead to psychological problems. I think that we have to address some real issues if we're going to think about these things from a social and psychological point of view, which is if you run a school and you have a class of kids in a school, my daughter attends a single entry primary school. The kids that have different abilities, some are better than others. They have to come to terms with that fact. Regardless of SATs tests, regardless of bullying, you give a kid some maths homework and some of them will do better than others. So differences between us are things that we have to deal with and we have to learn with that. You know, you enter into relationships and relationships break down. And there's a whole load of stuff. So for me, it boils down to what do you mean by internal and external stress? I profoundly believe that the difference between us in terms of our experiences of mental health problems is the variance that can be accounted for in terms of our different trajectories in terms of mental health can be explained by biological factors, biological differences between us, only to an almost trivial extent. And the reason why I believe that is that's what the data suggest. So these genome-wide studies that look for genetic differences find that they convey a tiny, almost imperceptible difference in risk. Whereas whether or not you were exposed to homophobic bullying in your high school has a massive impact on whether you're likely to take your life. So I actually do think that external stresses and the way that we have learned or been taught or been encouraged to respond to them, been parented in responding to them, is by far the major contribution rather than biological factor. And then finally, the patients themselves, yes, of course. So, you know, I'm an academic, I'm a clinician. I'll say my piece. I'll try to, I suppose, argue with people about my point of view. But it's not for me to determine. If people want to take antidepressant medication, then that should be their choice. I think that they should be given information about them. So, for instance, they should be given information that there is precious little evidence of their benefits at all over 8 weeks, despite the fact that people take them for a long time. People should be exposed to the fact that almost all of the arguments about the benefits of antidepressant medication, including the guidelines that I am a signatory to, are based on the positive effects of medication with no account taken of the potential harms. They were not included in the equation. And the adverse effects of taking medication long-term are quite striking. So I think people deserve proper information. I think that people need proper information about the limits of diagnosis. So people are told, you know, there exists a dangerous illness called schizophrenia. That's not an account of the facts that I would be able to support. I think about things differently. So I think people should absolutely choose, but on the basis of appropriate information. And then what data do we have? People differ. So there are people out there who profoundly disapprove of the message that I'm giving, who think that the message I'm giving is like Alex said, anti-psychiatry, is undermining the benefits of a medical approach. There are patients who say that they have profoundly benefited from the diagnosis and would be bereft if they weren't taking their medication. And they fear that the message I'm giving runs counter to that. I think incorrectly, they fear that I would be interested in taking away the things that they found useful. And I have absolutely no interest in that, of course. But there are also people who are profoundly damaged by psychiatry. For instance, there exists an anti-psychiatry movement. There isn't an anti-oncology movement. I mean, there's anti-vax, I suppose, but there isn't an anti-oncology movement. There isn't an anti-fracture movement. There isn't a group of people who are opposed to hepatic surgery, but there are people who feel that they've been damaged by psychiatry, large numbers of people. And in groups that I'm associated with, like MAD in the UK, MAD in America, groups like Drop the Disorder, people who associate with the harms they see done to them by psychiatry, yeah, those people have a profoundly different approach. When we've been doing research into this, most people are unaware of any alternative to the biological model of psychiatry. Most people have no idea that there's any sort of dispute over the concept of schizophrenia or the reality of depression as a biological illness. Most people think still that there is a serotonergic abnormality underpinning depression. Most people aren't aware of any of these conflicts. When we talk to people about it, a lot of people are excited and positive about an approach that could say that their difficulties emerge from the circumstances of their lives, and that there are things that we can do collectively in order to improve their circumstances that don't necessarily involve leaving the causal circumstances the same and changing their brain chemistry. So I take your point, and if I've worded it in a way that gives rise to misunderstanding, then that's my fault, not yours. But I do believe that the problems are real. I do believe that people are suffering immense distress. I believe that mental health problems are life-threatening and life-changing. I do understand the benefits the diagnosis brings. I know that it's not all down to trauma or abuse. And I know that medication helps people. But I do think that the root cause of the vast majority of our mental health problems are to do with the circumstances that we find ourselves in and the way that we respond to them. And I refuse effective treatment from nobody. All I want is for people to understand things in an appropriate point of view. So sorry if I'm being argumentative, but that's why. I should also say that my partner is getting a little bit anxious about where I am.
Have we got any more people wanting to ask questions? I can't see any hands up. Can anyone see any hands up? I can't see any.
5 minutes.
David's hand is up.
Yeah, I've got one.
Pardon?
Yeah, can you hear me okay?
Yes, who is that? Sorry, I can't see the person.
All right. Can anyone see?
Oh, fine. Yes. Okay, fine. Please go ahead.
Right. Yeah. Thank you very much, Peter, for that talk. It's really created a lot more thinking in my. I'm based in Sheffield. I'm chairing at the moment a Sheffield Mental Health Advisory Group, and I've done a lot of research over that. I'm a retired chartered psychologist. I've done a lot of research over the last 5-6 years in particular, but longer than that really. And one of the things that I'd be interested in your views on, of all the stuff I've looked at, it seems to me, you know, we're coming up to a general election. It's critical we get in a Labour government that has an educated and detailed approach to mental health and well-being. They haven't had. I did a content analysis of the general election manifestos 2017, 2019 of all three major parties. And I can tell you that if you do that, you'll find that they're all very fragmented. There's no strategy. It's very bitty. The difference now is, whether you like Starmer or not, he has made statements about prevention and early intervention and, you know, in terms of policy decisions. I'm a delegate to this year's conference in Liverpool in October. But what I'd be interested in your view on this. I've identified from a huge amount of work, some of the people you've mentioned and others, I've got it down to 3 Ps in terms of, you know, an overarching description that will be an indication of what we can do to create, you know, significant revolutionary change. The first is prevention, which, you know, some of these are obvious, but prevention, that means, you know, looking at poverty, looking at poor working conditions, low pay, poor housing, racism, sexism, homophobia. So we can do things on the prevention side. It takes longer, it costs more money, but we've got to do it. Secondly, it's about promotion. hesitate to use a hackneyed phrase from birth to death, but you know, we need to look at how mental health, you know, positive focus, you know, what do parents know about it, what do kids know about it, how do schools teach it, what happens in the workplace, you know, throughout life, how is mental health promoted, what do people know about it? And finally, which is the area that most people seem to talk about in my experience, is, you know, the mental health side of it in terms of the NHS. And by that, the data seems to talk in terms of progressive development and delivery of evidence-based approaches for those people who are suffering from what a bit termed mental health conditions. I mean, we need some steer that is, it doesn't need to be simplistic, but we need some overarching easy way to conceptualize it all and then feed it to politicians so they'll do something about it and take action, which clearly hasn't been taken in the past. And big picture, we need to be moving into a different era. I believe we need to be, and we could be on the cusp of it, where you know, we won't talk about mental health as such. We will talk about, you know, the kind of society that we used to talk about as socialists, about the kind of society we want to create, where work is not taking the lead, people aren't working all the time, you know, they're developing all kinds of other interests in the community-led, local community. You know what I mean? It's that kind. It's real. We need a sea change, revolutionary change in how we look at these things. So I'm interested in what you're, you know, are you able to give a, you know, a categorization that politicians can easily understand and look to implement?
Thanks. Yes. So, I mean, again, I was just picking up on sort of reflecting rather bruisedly on Ruth's point about withdrawing services. So no, I agree with all of that. So, but I think this then starts to highlight some of the points of agreement, but I suppose differences in practice of what I would suggest as opposed to others. So prevention. So if you were to think, if you were to believe, I think some of the guff that people have been speaking over the years, that, you know, schizophrenia is a devastating brain disease, that depression is one of the you know, medical challenges of our time, and so on and so forth, and see them all as predominantly biological illnesses, then prevention would be biological in nature. You'd be thinking about cat fleas causing schizophrenia, or a lack of lithium in the drinking water causing depression, that kind of thing. If you see depression, for instance, as social and psychological, then you've got to be thinking, what is it that gives people a sense of meaning and purpose in life? What gives people motivation? What engages people in the business of being alive and contributing to society? And you would come up with a very different thing. In other words, the building of community resources would be an antidepressant effect. So you wouldn't put lithium in the drinking water, you'd strengthen social cohesion at the community level. Now, it might be expensive, but it's the right thing to do. When it comes to sort of secondary prevention, I suppose, rather than primary prevention, again, there are differences. So I and colleagues are quite worried about things like mental health first aid. So what you do is you have a high school, and there are loads of kids who are anxious and loads of kids who are depressed, and you get some self-harm, and you get a lot of people school refusal, and you think, we've got a mental health problem. What we need is to train people up to be mental health first aiders. And the traditional approach to mental health first aid is to say, you go off on a course to be a mental health first aider, and it's like ER, right? It's like paramedics, which is, you know, Dave 27, come in. There's a sad kid in classroom 3, and you dash off, and you go, are you sad? And the kid goes, yeah. And they go, right, okay, I need to, right, let's do a diagnostic interview with you to see if you've got the disease of depression. Oh my God, there's early warning signs of depression. Let's get the medication in stat. Give me a Chem 7 and sertraline quick. And you just, no, that's not the approach. What you do is you go, if we've got psychological, social perspective, you go, okay, we talk to the kid about why they're unhappy. We don't slam in with early diagnosis and early intervention. We find formulation again. Why are you unhappy? Why are you miserable? And if they go, I don't like this bloody school, the teachers are crap, you go, okay, we'll deal with that then. rather than you see that's another symptom of a mental illness. So the mental health first aid stuff, secondary prevention, is widely touted. I have worries about Rosina Alin Khan and the idea of mental health specialists in schools, because what sort of ethos are they going to use and what sort of intervention? I absolutely do not believe that we are under-medicating our kids. I do not believe that we are using psychoactive medication too sparingly with our children. I think we're using it too liberally with our children. And I think that we need to identify the causes of sadness, misery, and unhappiness in our children, and then respond to them educationally, socially, and psychologically. So I would worry about what secondary provision would be. So yes, I want mental health specialists in schools, but I want them to sit down and talk to the kids, come up with a formulation for why they're unhappy or anxious or worried. And then they need to engage at the social level with the reorganization of the classroom, with interventions with their friends and family, and maybe even parents, trying to get to the root cause of why they're unhappy and do something about it, rather than diagnosing, mental health first aid, rapid diagnosis and rapid intervention. The same is true when it comes to adults, of course. So yes, I believe in social prescription, but I don't believe that going for a walk in the park is a prescribed treatment for depression. I think what we're doing is building a local community where people are more active, more purposeful, more connected. So therefore they're less depressed. So yes, I want all of that stuff, but I want the overarching ethos to be one of a social and psychological perspective on healthcare, rather than another diagnose and treat response. So yeah, and I think that that's a slightly different approach to healthcare workers. When I live in Manchester, so just down there is Chorlton Ease, and there are big signs on the entrance to Chorlton Ease saying this is partly funded by the local health authority or local NHS trust. Quite right too. Nature is good for our mental health. So we need to be thinking about community resources. We need to think about school and local communities. We need to think about building those networks so the kids feel every morning that they've got a reason to get up, that their friends are supportive, that their problems will be understood and addressed, that their teachers will support them in developing in the best way they can, that they've got a future to work for, that if they're not academic, that they'll have other things that the community will value. That's the sort of work that I want us to be doing. Not more biomedical specialists putting psychoactive drugs into kids. So my point is, yes to all of that, and yes to increased resources, and yes to mental health specialists working across the board and with all age groups. But the ethos has got to be the right ethos. And then the people will be trained and developed and skilled in the sort of interventions that we need. I still work for the University of Liverpool. I know a lot of senior people at the University of Liverpool. I'm pretty much hacked off with it. And that should not be the case. But I don't get less hacked off at the university by giving me more serotonin in my frontal lobes. I stop being hacked off at the university if they don't randomly sack 57 people because they've got some model of making people more motivated by being horrible to them. It's the ethos that matters. That's what's important.
I'm proud about the National Health Service. It's a piece of real socialism.